Hello, my name is Denis Smirnov. I'm an MD PhD student at UC San Diego, and today I'd like to tell you about some of the work we've been doing at our Alzheimer's Center to examine how concomitant late pathology influences the clinical presentation and progression of individuals with PART and early stage AD. PART, or primary age-related tauopathy, is a recently identified constellation of pathologic changes consisting of tau pathology generally restricted to the temporal lobe in the absence of significant amyloid pathology that would otherwise characterize this as Alzheimer's disease. Yet despite the restricted spread of the tau pathology, a fair number of individuals with PART at autopsy were cognitively impaired or even frankly demented in life. Studies have shown that higher Braak stages of tau spread and the density of the tau burden correlate with this cognitive impairment, but even so, many individuals with Braak stage 1-2 PART demonstrate more clinical impairment than would be expected for this degree of pathology. Some have suggested that concomitant pathologies may play an important role in explaining this impairment, and studies have shown contributions from cerebrovascular disease and RTAG, though these still do not account for all of the unexplained impairment. One additional pathology that may contribute is late, which similarly to PART has a predilection for older ages. Studies have shown that late does co-occur with PART in up to a third of cases and is associated with more rapid hippocampal atrophy and neuroimaging. Unfortunately, many of the early studies to characterize PART were done in large historic cohorts such as the NAC UDS 1 and 2, in which assessment of TDP-43 was lacking, and it remains unclear whether some of the cognitive impairment out of proportion to the tau pathology of PART may actually be attributable to the concomitant late. In our study, we sought to address this question by assessing the contribution of late pathology in PART, that is tau phase 0 through 2 with Braak stages 1 through 4, and a matched set of individuals with more amyloid that would classify them as early or low AD neuropathologic change, NC. For reference, we also included a sample of age-matched cases with high AD NC with Braak stages 5 through 6. Importantly, we eliminated all individuals with other concomitant pathologies at autopsy that may contribute to cognitive impairment, including any Lewy body disease, FTLD, infarcts, and other rare pathologies, leaving only individuals with various amounts of amyloid, tau, and TDP-43 pathology. We can see that while the low AD and C group was more likely than PART to have an ApoE4 allele, the two groups were generally at comparable levels of impairment in their final clinical evaluation, and nearly half of each group received a dementia diagnosis prior to death. When we look at the degree of concomitant late pathology on the right, we can see that both PART and the low AD and C group have identical levels of TDP-43 positivity at 23%, both substantially less than the age-matched severe AD group. When we look at the contributions of late to the degrees of impairment in these groups on the mini-mental states, the dementia rating scale, and the clinical dementia rating sum of boxes, we can clearly see that those with concomitant late in orange are more impaired in both the PART and the low AD and C groups across the board. In regression models that test for the contributions of thaw phase, low versus high Braak stage, and the presence of a late pathology, we can see that it is late that is the major driver of impairment, with some contribution from Braak stage, but no differences between PART and low AD and C. If we use mixed effects models to look at the rates of cognitive decline in the 5 years prior to death, we can see that while the high AD and C group in red showed rapid decline, both PART and the low AD and C group exhibited slow and similar rates of decline. If we divide these two groups by the presence of late pathology, we can again see more rapid decline in those with concomitant late, regardless of the degree of amyloid pathology or Braak stage. On the right, we can see that in the high AD and C cases, there's also a trend towards more rapid decline with late, but this did not reach statistical significance. Finally, if we test for factors that predict dementia in the PART and low AD and C groups, we can see that higher Braak stages and the presence of concomitant late are the major determinants with odd ratios of nearly 1.5, while there is no distinction between PART and low AD and C. On the left here, we can see that while the majority of the low Braak late negative individuals were cognitively normal at their last evaluation, either Braak stage 3 through 4 or concomitant late pathology was enough to result in dementia. Turning this on its side, we can see that of those individuals who died with dementia, the majority had either higher Braak stages, late pathology, or both. So in summary, we showed that late pathology is common in PART and low AD and C and is a major determinant of the degree of impairment and decline. Indeed, most cognitively impaired individuals with PART or low AD and C had either higher Braak stages of tau spread or concomitant TDP-43. Overall, this suggests that late pathology may explain much of the impairment that appears out of proportion to the degree of tau pathology in studies of part that do not assess TDP-43. And with that, I'd like to thank my co-investigators, and especially Annie Hineker, our neuropathologist, as well as the study participants, the ADRC faculty and staff, and our funding sources. And of course, to you for listening. Thank you.